Good afternoon. My name is Vince Rock, Program Manager here at the American Brain Tumor Association. The ABTA is pleased to welcome you back to our webinar series. Today's webinar will discuss treatment strategies for meningioma. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, please type and submit it using the question box in the control panel on the right-hand side of your screen. Our presenter will answer questions at the end of the presentation. The webinar will be recorded and posted to the ABTA website within the next week. Registered participants will receive the webinar recording link in a follow-up email message tomorrow. In the next few days, you will receive an email asking you to take a brief survey to evaluate the webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. I'm delighted to introduce our speaker today. Dr. Stephen Giannotta is Professor and Chair of Neurological Surgery at the Keck School of Medicine of University of Southern California. He has special expertise in cerebrovascular neurosurgery, surgically treating over 12,000 intracranial aneurysms, and in surgical approaches to the cranial base for removal of tumors and vascular lesions. He has also held leadership positions in many of the prominent national organizations within organized neurosurgery. Thank you very much for joining us, Dr. Giannotta. You may now begin your presentation.
Thanks very much, Vince. It's an honor and a pleasure to interact with all of your listeners. I'll have to say that USC has been a long-standing supporter of the ABTA, and I'll also give a little plug because on October the 26th, the USC is sponsoring a brain tumor walk on USC's campus for the ABTA. So again, we want to emphasize the kind of support that and the kind of respect that we have for the organization. So the topic today is meningioma. And I'm sure that a lot of your listeners know that meningioma is supposedly a benign tumor. I'm going to modify that a little bit with the talk today because meningioma is much more complex than people give it credit for. So I'm grateful for the opportunity to explain that to a lot of your listeners. My co-author is one of our very excellent neurosurgical residents in training at USC who someday will become an expert in managing cranial-based tumors like meningioma. So I'm proud to have him as a co-author. A couple of facts. Most of your listeners probably know a bit about brain tumors or they wouldn't be listening, but meningiomas make up approximately a little over a third of the tumors that occur within the brain cavity. Unfortunately, the rest of the tumors that are there are mostly malignant tumors. So we're talking about somewhat of a minority of tumors when we talk about meningioma. They come from the coverings of the brain, not so much, they don't come from the brain itself. They actually come from cells that cover the brain, which causes them to, rather than invade the brain, to compress the brain, which is in many ways a good thing as compared to other brain tumors that are within the brain. About 30,000 new diagnoses are made per year. They tend to be an adult condition. Children don't get meningiomas. Children get other kinds of brain tumors, but not meningiomas. We first start seeing patients with meningiomas usually in their 30s or 40s, with the average being in the 50s. As you can see from the slide, the prevalence is about 100 per 100,000 in the United States, and as far as meningiomas of the brain are concerned, females get them more commonly than males. That's some basic meningioma statistics. One of the unfortunate aspects, though, of meningioma is there are subtypes that are much more aggressive and much less benign than is typically thought. And so we'll talk a little bit about that later on. Options for patients with meningiomas can span simply observation for tumors that may be small and are not causing problems, may actually be diagnosed accidentally because patients may have had a head injury or something like that and got a scan and found the tumor incidentally, all the way to surgical cure. And for those that aren't curable, which admittedly are a minority, but an important minority, and we'll talk about that, there are other options for treatment, which we will go over. Unlike most of the other malignant brain tumors, meningiomas, as you can see by these cartoons, are actually tumors that aren't part of the brain, but they do compress the brain. They start underneath the skull, and in most instances compress the cerebral hemispheres in one area or another. I plagiarized these two drawings from my associates at the Cleveland Clinic. Each year, the Cleveland Clinic's Brain Tumor Center and USC's Brain Tumor Center get together and put on a professional symposium. And I don't get a chance to talk to lay audiences like we have today, so most of my slides are highly technical in nature. So I borrowed these slides from my Cleveland Clinic colleagues, but they depict the fact that as these meningioma tumors grow, they start on the outside of the brain, and as they grow, they compress the brain. And many times they can actually grow so slowly, and the brain is able to be deformed away that no symptoms occur as a result of these tumors. And so some of them can become very large before the patient even knows that they have them. My message today is going to be that meningioma is not a single disease entity, and it has a lot to do with the myriad of ways that these tumors present themselves and the myriad of ways that they can cause trouble, and not to mention the different methodologies we have for treating them. Presenting symptoms, as one could imagine when we saw those last cartoons, the most common presenting symptom would be a headache. Since that tumor is taking up space inside the head, pressing on the brain, headache is one of the more common symptoms of meningioma. Some of the listeners may know of patients or be a patient whose tumor was discovered without headache, and we'll talk a little bit about how that can occur. As you saw from the cartoons, most meningiomas occur underneath the calvarium. The calvarium is the big part of the skull. That's the hair-bearing part of the head. But there are other locations underneath the brain at the so-called cranial base where tumors can occur. And these are much more difficult to manage, and they cause symptoms much more frequently than those over the calvarium. Even though they're supposedly benign and slow growing, each meningioma has its own consistency, and consistency is how soft or how firm the tumor is. And we'll talk a little bit about that when it comes times to talk about what do we do for these tumors in terms of removing them. I'll show you a scan of a patient who had what's known as hyperostosis. Hyperostosis is overgrowth of the bone as a result of the presence of the tumor. Some patients can even present with a lump underneath the scalp as the first sign of a meningioma. So it's very unusual in that regard. Unhappily, meningiomas can become malignant and can present as a malignancy, in which case they can invade the brain and cause damage to the brain just by their very presence. And they are much more difficult to cure when in that circumstance. Also, when we come to talk about treatment of these tumors, We know that some of them will engulf the very important nerves that come out of the base of the skull that go to the eye or the ear or other places, and they can engulf also the blood vessels that supply blood supply to the brain, making their treatment even more problematic. We know that meningiomas are, quote, slow growing, unquote, but they do grow, and some of them grow faster than others, which raises the specter of the importance of getting surveillance if patients have one of these tumors, that it's decided that they're not going to undergo any treatment in the near future. One has to become very vigilant about watching that tumor with respect to getting CT scans and MRI scans. Unfortunately, they can recur even if it seems that they've been cured with surgery, and so surveillance imaging is important in that regard. And then finally, the World Health Organization, which is depicted by those three letters WHO, grades meningiomas, or has developed a grading scale for meningiomas: grade 1, grade 2, and grade 3, grade 1 being the most benign and the most curable, and grade 3 being the most malignant. How about presentation? How do the patients present? Well, they vary widely. The presentation symptoms vary widely, but we talked about headache. Another one is cranial nerve palsy. If this tumor is located near, let's say, the optic nerve, the nerve that gives vision, then patients can present with blurry vision. Since tumors also, as you saw by the cartoon, they indent the surface of the brain, they can present with an epileptic seizure. That might be the first and only indication that a patient has a brain tumor, and that includes meningioma. If you look at the two scans, these are both MRI scans. The one on the upper left here presents the front of a patient's brain, with their eye sockets being one here and one here. And so right in the middle behind the nose is this little meningioma. That meningioma happens to sit exactly where the nerves that produce smell are located. And so this patient may have presented with a complaint that they can't smell their food anymore. On the other hand, looking at this scan, which is another MRI scan, looking from the side, you can see this very large tumor compressing the frontal lobe. We know that the frontal lobe of the brain carries a lot of information related to personality and memory. And this patient may have presented with personality changes that the family began to notice, or maybe forgetfulness, and took the patient in perhaps to the neurologist because their memory was failing, and a scan showed the reason for that, and that was because so much pressure from such a large tumor on the part of the brain that gives one executive function. Depending on whether or not these tumors involve the base of the brain and the nerves that go to the eye, visual disturbances could occur. Or if the tumor is in the back part of the brain, we know the back part of the brain is the vision part of the brain. A tumor back here can cause blurred vision off to one side, and that could be the beginning symptom when a patient goes to the eye doctor and says, "Hey doc, I need new eyeglasses," and the optometrist examines the patient, finds no evidence that there's anything wrong with the eyes. That's when it's important to be evaluated perhaps by a neurologist or a neurosurgeon, and a scan be done to make sure that there's not a tumor involving the visual pathways of the brain. We know that some patients will find their tumors accidentally or incidentally, and not an uncommon phenomenon is in a minor car accident. You go to the emergency room, you've got a headache, and they do a scan, and it shows maybe a small or maybe even a large brain tumor. Here's a scan. This is a CAT scan, and this blue arrow shows an area of the skull that clearly is much thicker than the normal skull. And this is on the patient's left side, and this patient presented with a lump next to their eye that nobody could figure out why they had that, and the scan was done and very easily showed the fact that there was this so-called hyperostosis which was associated with a meningioma that, rather than put a lot of pressure on the brain, actually caused the bone to overgrow, causing the deformity of the patient's skull. As you can see from the slide, the treatment of that is going to have to involve some removal of all of that excess bone and the dura, which is the covering of the brain that housed or that supplied the blood supply to that tumor so that it could expose the bone to all of that overgrowth. That all has to be removed in order to get a surgical cure. It presents a couple of challenges for the surgeon because this obviously is in a cosmetic area. So what we do in that circumstance is we take usually some material like either fiberglass or possibly titanium mesh, and we reconstitute the contour of the skull so that the cosmetic result is highly acceptable. Location is one of the confounding factors in the meningioma management. We talked about how location affects the presentation or the symptoms, but obviously location affects the treatment. And in these cartoons where the tumor is out here on the surface of the brain underneath the calvarium, which is the thin part of the skull and the hair-bearing part of the skull, it's a relatively simple matter to remove that portion of the skull and access the tumor. However, as you can see by all of these dots, this is a depiction of the places where meningiomas can occur at the base of the skull. The base of the skull in this picture has the brain removed, and you're looking at the skull base where the brain sits. And all of these dots represent various locations of where meningiomas can occur. Now, all the little holes that you see in this drawing are places where nerves exit to go to the face and the head and the ears and the eyes and so forth. So you can imagine how tumors in this area can cause problems with those nerves, double vision, hearing loss, imbalance, and etc. Further, if we place the brain back in position over these dots, it gives you some idea of what the surgeon has to go through in order to access the tumor and not disrupt the overlying brain. We'll talk a little bit about that. So issues that complicate treatment. Here's two MRI scans, both of which depict a meningioma, but two very different kinds of meningioma. Let's start with the one here on the right side of your screen. This is a base of the skull meningioma. Remember, it doesn't involve the calvarium up here. It presents very close to an area where the optic nerve is, so this patient may very well have presented with blurry vision of the right eye. The blue arrow points to a dark T-shaped structure in the middle of this white meningioma, and that T-shaped structure is actually the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery. All three of these arteries supply all the blood supply for the right-hand side of this brain, and they are clearly engulfed by this tumor, which makes treatment of this tumor, especially the surgical treatment of this tumor, obviously much more risky and much more difficult, underscoring the need, if any of our listeners or our patients or our caregivers know of patients with this kind of tumor, to ensure that they have a tumor like this evaluated by a team that has a lot of expertise in dealing with tumors of the cranial base and tumors that engulf these blood vessels. On the other hand, we have another very large tumor underneath the calvarium, which, as we said before, is a relatively easy access. But this tumor not only has compressed the brain, but this white area in the brain is indicative of a tumor that is now starting to invade the brain. So to get inside the brain cells and the brain tissue and cause this white area to occur, which is swelling. It's called edema, which is another potential complication of not only having this tumor alone, but also when it begins to invade the brain. When tumors invade the brain, we know that they have a much higher likelihood of being one of those WHO2 or WHO3 tumors, which are not benign and therefore a lot more difficult to treat. Another factor in how tumors are treated and how easy they are to, let's say, surgically remove, which of course gives the patient the best chance for a cure, is the consistency of the tumor. And this is a study that we did at USC and published in the literature, looking at the grading system for the consistency of a tumor, with a grade 1 tumor being extremely soft and thereby being much more easy for the surgeon to remove. And hopefully that translates into a better surgical removal and a much greater possibility of cure. And I'll show a slide that shows that. All the way down to the grade 5 tumor, which is extremely firm, might have calcium in it, certainly is very fibrous, has a rigid capsule, and even with the automated instruments that we use during brain surgery, it's very difficult to get some of these tumors out and maintain a beautiful margin between it and the nerves that it might be compressing or the brain itself. So a much less chance of getting a surgical cure with a grade 5 tumor than obviously with the grade 1 tumor. And there are some hallmarks of the MRI scans that can give the surgeon and the patient some idea of whether or not they're dealing with a soft tumor or a firm tumor, and that's a good question for patients to ask surgeons when contemplating a surgical removal. This slide shows our results with our series of tumors that we studied, looking at the consistency versus the surgical cure. And the blue represents surgical cure, and the orange, I guess this would be, represents a failure to get a surgical cure. And these are the grade 1s, so these are the soft tumors. So obviously the blue is much higher with the softer tumors. As we get to the consistency of the more firm tumors, we see there's less blue and more orange, which means there's, in this particular case of the very firm tumors, there's less than a 50% chance of getting a surgical cure the first time around due to the consistency of the tumor. Finally, one of the more difficult slides for you all to interpret, but something I'm going to make as easy as possible. Remember what we said about the World Health Organization. The World Health Organization has provided a grading scale for meningioma, and it has 3 grades: benign, which is the grade 1, atypical, which is the grade 2, and then unfortunately malignant, which is the grade 3. And the pathologist, once they get a piece of the tumor from the surgical specimen, can look at the tumor, put these stains on the cells, and get an idea, and get a very good idea, as a matter of fact, on whether the tumor is a malignant one or hopefully the benign one, which obviously gives us a much better chance of getting a surgical cure. One of the things I'm going to emphasize later on is the fact that we've now come to realize that a 3-point grading scale is really insufficient to characterize meningiomas. We know now from more in-depth genetic studies that meningiomas can be much more varied than just 3 typical categories. And so we'll talk a little bit about that in a minute. How about management? Once the patient discovers that they have one of these tumors, what are their options? And so obviously one needs to seek the counsel and a consultation of neurosurgeons. Neurosurgeons are the subspecialty of medicine that deals most commonly with meningiomas, and in fact probably no treatment, whether it's any of these options on the slide here, whether it's surgery or radiosurgery, which we'll talk about, or even chemotherapy, should not be done without the oversight of a neurosurgeon who is clearly the expert in the management of these tumors. Happily, surgical removal is an option for the majority, probably over 90% of meningiomas. And that brings up the specter of having a cure, which means if the surgery is successful, the tumor is gone. There is a 80–90% chance it may never come back again the rest of the patient's life. And if the surgery obviously can be done effectively and safely, I always tell my patients you can spend the rest of your life forgetting about your tumor. As we discussed with some tumors, especially in difficult locations or those that may have invaded the brain or engulfed some of the very important nerves or blood vessels, total removal may not be possible because it's not safe for the patient. And in that circumstances, the surgeon may elect to remove the majority of the tumor and leave a strategic portion of the tumor that might threaten either one of those important blood vessels or one of those important nerves or some important area of the brain that might undergo some sort of injury as a result of the surgical procedure. And the surgeon may elect at that time to leave a strategic portion of the tumor behind, recognizing that the majority of the tumor is removed and perhaps the pressure on the brain is mitigated and the enough of the tumor is removed to mitigate the headaches and actually reverse some of the symptoms that the patient experienced because of the tumor. And that is a very thoughtful strategy because remember, for the most part, we're dealing with a benign situation. We're not dealing with necessarily a threat to the patient's life. So subtotal removal that's done safely may many times be in the best interest of the patient. However, we'll talk about this a little later, but with subtotal removal, one must realize that, well, there's still tumor in there, and we're going to have to do some surveillance imaging over time, see if the tumor regrows. Sometimes it doesn't, happily, and sometimes it does. And so in those tumors where surgery cannot cure the entire lesion, that's where radiosurgery as an adjunct comes in to play, and we'll talk a little bit about what that means. The other option is, rather than use surgery at all, to use radiosurgery to treat the tumor. Now, what is radiosurgery? Radiosurgery is an X-ray technique. It's radiation. However, unlike radiation for cancer, and I know a lot of our listeners have experienced either friends, relatives, parents that may have had a malignancy like breast cancer or lung cancer, something where they had to go in and have, let's say, 30 treatments of radiation in order to stop the cancer from growing. Radiosurgery, on the other hand, is a single, in most cases, a single dose of radiation. It's an extremely high dose of radiation, but it's focused with a stereotactic device. We'll talk about the Gamma knife, which is the one that we use preferentially at USC, that can aim the beams of radiation so precisely that they only hit the tumor target and don't spread to the surrounding brain. Those of you that have experienced radiation or know family members that have know that that radiation can affect other organs, and especially the skin. A lot of people will lose their hair because of the spread of the radiation. In this circumstance, the radiation is so precisely aimed that we reduce any spread of the radiation to the surrounding normal structures of the brain or the nerves to the point where we can give an extremely high dose of radiation and stop even a benign tumor like a meningioma from growing. When all else fails and there's a grade 3 tumor, we'll talk a little bit about what chemotherapeutic options are available. I said that some patients find their tumors by accident, and some of them are very small and are not causing any symptoms. We know that Meningiomas can be slow growing, so in that circumstances, a treatment option will not be selected, and it'll be the better part of judgment to simply take an image, an MRI scan or a CAT scan of the tumor every so often to see if it's in a growth stage. If it is, then the treatment can be prescribed, and if it's not, and it's not causing any difficulty, and the images are quite representative of a meningioma, then in many circumstances, the neurosurgeon will elect not to treat the tumor until or unless it either grows or causes a symptom. And in many instances, in our more senior aged patients, they can live their entire rest of their lives without needing to have the tumor be treated. Here's an example of a case that had surgical removal. This is a very beautiful woman who is a therapist, and she noted that she was starting to have headaches and was having a little bit of memory trouble. And here's her tumor. It's on the left side. It's affecting the left temporal lobe, which we know houses a lot of the memory of the brain. And so it was pretty easy to determine what was causing her difficulty. Here's a base of the brain axial, so-called axial scan, where you can see the two eyeballs. And you can see that this is involving actually the left temporal lobe. And here's after the surgery that we did, and you see the blue arrows depicting no evidence of any tumor remaining. So this patient very likely has a surgical cure, probably will live the rest of their life without having any more difficulty with this tumor. We have a way of keeping score, those of us that do tumor surgeries. It's called the Simpson scale, and it has to do with how much of the tumor is removed and whether or not there's a chance that the tumor will come back. A grade 1 on the Simpson scale is a complete so-called microsurgical removal of the tumor, where not only do we take the tumor out, but we take the bone adjacent to the tumor and the covering of the brain adjacent to the tumor, so as to get every last bit of cell material in hopes that we can get a surgical cure. We know that if we do that, less than 9% of patients will get a recurrence in the next 10 years and probably for the rest of their life. So 90% of patients with a grade 1, with a true grade 1, will be actually cured for life. The other grades are, as you would imagine, indicative of less complete tumor removal. And in the instance of a grade 2, there's about an 80% chance that the tumor won't come back in the patient's lifetime, all the way down to a grade 5, which we rarely, if ever, do, which is simply exposure of the tumor, decompress it by taking off the bone around it and taking a biopsy. We know that, of course, since you didn't really treat the tumor, 100% of the time, if the patient lives long enough, the tumor will become symptomatic again. We rarely, if ever, use that that modality for a brain tumor surgery. How about those patients where surgery really is not the answer? And we talked a little bit about this before, but some of these scans, now that you're experts in reading these scans, here's again the two eyeballs, and here's the base of the brain, and here is a tumor that again is engulfing the blood vessels at the base of the brain, probably is down by the optic nerves, causing visual loss, probably is also involving the pituitary gland, so patients may also have hormonal problems. Young women that get these meningiomas can have problems with their menstrual cycle. Another case of a tumor at the base of the brain that involves the nerves that go to the eyeball, and several others. These tumors, it's very difficult to get a Simpson grade 1 surgical removal. And in many instances, we only try to get a subtotal removal and then use some adjuvant therapy for the rest. And sometimes we may not even elect to try to do surgery at all, but use radiosurgery. We know that due to the location of the tumor, as I just showed you, or engulfment of nerves or arteries or blood vessels, or invasion of the brain, or the surgeon actually tries to get the tumor out, but the consistency of the tumor is so firm that it's unsuccessful. And in those circumstances, these tumors aren't necessarily curable by surgery, even in the best of hands. So we need other alternatives. And that's where radiosurgery comes in. We use the Gamma knife, although at USC we have the Cyber knife and we have other modalities that you may have heard of, but the Gamma knife is sort of the mainstay of our treatment options here at Keck. As we said, it's a radiation technique. However, it's a precision targeting of many beams, and in fact, the Gamma knife has 201 separate radiation beams. We give a very large dose centered right in the middle of the tumor. It's a single treatment. You're not admitted to the hospital. You come in the morning and you go home in the afternoon. So in effect, it's an outpatient treatment. It's relatively safe, and I'll show you some statistics about complication rates. Remember, most importantly, for everybody that's going to experience stereotactic radiosurgery for benign tumors like meningioma, it does not make the tumor go away. It simply controls the tumor's growth. I like to tell the patient that it stuns the tumor and stops it from growing. And it may actually stop the tumor from growing for the rest of the patient's life. It certainly can stop the tumor from growing for 5 to 10 years and longer. Unfortunately, not all meningiomas can be treated with stereotactic radiosurgery because there is a size limit. Any tumor that's greater than 3 centimeters, which is about 1.5 inches in greatest diameter, really cannot be treated by this form of radiation. We can't do single dose gamma knife treatment for tumors larger than that, which brings us back to that list of treatment options that I showed you, where one of the options was surgery and radiosurgery. In the case of a tumor that's not able to be totally surgically removed, if the surgeon does a good enough job to get the tumor down to below 3 centimeters in diameter, then the rest of the tumor can easily be treated with radiosurgery. And here's a typical plan that we create as an outpatient. The patient gets an MRI scan or a CT scan, and then we plot using a computer the tumor and plot where all the 201 beams are going to converge right in the center of the tumor, so that these beams individually penetrate the brain, but they don't penetrate the brain all together, thus not injuring the brain. And you can see the sophistication of the dosing of the radiation so that we aim only precisely at the target. So to decide that we're going to use radiosurgery or gamma knife treatment as the primary treatment for the tumor, it has a lot of variables, including the patient's age. We know that we can control the tumor for 10 years or more, but we don't know that necessarily that we can control a tumor for 40 years. So a 30 or 40-year-old patient who comes to us with a tumor, we may be more likely to offer surgical removal than radiosurgery. However, a 60 or 70-year-old patient that comes to us, we may be very likely to offer primary treatment using the gamma knife. The tumor location and the surgical risk all come into play in terms of deciding whether to use gamma knife or surgery. How healthy the patient is obviously has a lot to do with it. Patients with a lot of medical morbidities like heart disease or lung disease, maybe they're not a very good candidate for general anesthetic and the open surgery, and so gamma knife radiosurgery might be the best option for them. Patient preference also. What are the risks? They're relatively low. The chances of hurting one of the nerves that's at the base of the skull with radiation is less than 6%. And the possibility of causing swelling of the brain adjacent to the tumor target is also less than 6%. So over 90 to 95% safety in using this technology. Here's an example of a patient that got gamma knife to this relatively small meningioma several years back, and now follow-up images show the tumor to be not growing at all. This slide gives some idea of the amount of tumor control depending on the location. So those lesions at the base of the skull that I showed you that may not even be amenable to surgery, we can get a 96% stoppage of growth for 5 years and an 84% stoppage of growth for 10 years in those kinds of tumors. In the area of the cavernous sinus, which is an area where all the nerves come together that go to the eye, we can get a 90% control rate for 10 years if we use a certain dose. If we fall below that dose, which we don't do anymore, of course, then the chances of controlling the tumor are less. So you can see these are fairly favorable statistics for stopping the tumor from growing for 6 to 10 years. And so for our more senior aged patients, this is an excellent modality. For those patients who have residual tumor, the gamma knife radiosurgery, or so-called GKRS, can be used as an adjuvant, and those tumors are treated that way. They are unable to be totally removed with surgery. Or in those tumors I told you about that are grade 2 or grade 3, which means they're much more aggressive, and in the case of the grade 3 tumor, much more malignant. Radiation can control those tumors much less than the benign, but certainly much better than if we didn't have radiation at all. Just a couple of examples of tumors that were unable to be surgically removed, and after several years, we still have the tumor being the same size after treatment with radiosurgery. How about those unhappy tumors that are grade 3? We have a protocol for those. We try to get as much of that tumor out surgically as possible, but we know that if you follow the patients for 2, 5, or 10 years, their survival rate is much less and maybe as low as a 40% survival rate. And in that circumstance, we need to have a paradigm that we follow to treat those tumors. And in certain circumstances, it may even involve some form of chemotherapy, such as hydroxyurea, interferon A, or sandostatin. I'm happy to say that there are other chemotherapeutic agents that we are working on at USC to treat these more malignant forms of meningioma. And in fact, we are working on a chemotherapeutic agent that we provide by inhalation. The patient actually breathes it in through their nose and doesn't even need to have an IV to get that chemotherapy. So more about that in the future. And finally, how about not doing anything? Well, in small tumors, obviously the picture that I'm showing here is anything but a small tumor, but for small tumors, it may be meaningful to simply just take pictures of the tumor with MRI scans every so often to determine whether or not it's growing slowly or more rapidly. I'm very unhappy when I have a patient come in to see me that has a tumor this big, who was told 5 years ago, oh, you've got a meningioma. We know they're slow growing, so don't worry about it. It'll never grow. Unfortunately, that isn't the case. If you have a meningioma, you didn't have it when you were born, so clearly it's growing and it needs to be surveilled. About the future, happily, and at our institution, we are studying the genomic and the chromosomal abnormalities that produce these meningiomas, and someday we're hopeful to have a precision medicine program where we can plot the chromosomal and genetic abnormalities that cause these tumors to grow and to become malignant, and be able to treat them with genetic intercessions that can mitigate the growth and perhaps the malignancy of these tumors. And so in conclusion, I'd like to say that even though most meningiomas are benign and curable, it's not a single disease process. the complexity of the surgical resection varies widely, and therefore the ability to get a cure varies widely. Just like in real estate, location, location, location depends on where your tumor is as to how easy it is to cure, and not all tumors can be cured. Always seek a second opinion at a reputable tumor center, especially if your physicians are telling you that you may have one of these tumors that won't be easy to cure. And those of us who are in a senior age range and are going to not treat our tumors, remember long-term surveillance is imperative because they still can grow. So thank you very much for your attention.
Thank you, Dr. Giannotta. We will now take questions from our viewers. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We will answer questions as time allows. So, Dr. Giannotta, our first question is for people who have had treatment, they've made it through recovery, maybe they're doing follow-up visits with their doctor. What kind of information should they share with their treatment team to better inform the treatment team about future options?
So you're asking what information should the patient provide the doctor when the patient is being followed up by the doctor? Is that the nature of the question?
That's correct.
Okay, so both the doctor and the doctor's nurses or physician's assistant will usually quiz the patient with a sort of a checklist of questions about how they're doing. And a lot of that has to do with what treatment the patient had. So for instance, if they had a surgical procedure, the first thing they're going to want to know when the patient comes back is what's their level of activity. And that's the first question I always ask my patients. We do a quick exam to make sure that there are no new neurological symptoms that are occurring. So if a patient presented with headache and maybe double vision, and the tumor was removed and the double vision went away and the headache went away, then we're going to want to know, has the headache come back? Has your double vision come back? That sort of thing. Secondly, we want to make sure that the patients get back to full functionality. If that tumor is cured, I want my patient to spend the rest of their life forgetting about it, and the only way to do that is to get back to all of their normal daily activities. And in order for that to occur, they need some form of physical exercise in those weeks after their treatment. And if they do that, then the chances are very good that they'll get back to their normal activities. If they come in and say, "Doctor, I'm really not recovering well," then it may very well be that the patient may need help with some form of exercise therapy or physical therapy. So it's important to convey to the doctor how much activity you are experiencing as a post-operative or post-treatment patient.
Thank you. And at what point does the medical team consider additional treatment strategies beyond therapy? So, for example, another round of surgery or radiation?
Correct. Good question. For the most part, and especially in our institution, we only prescribe the next form of treatment or adjunctive treatment in the case of those patients who, number one, did not get full relief from the symptoms for the first treatment, whether that be radiation or stereotactic radiation or gamma knife radiation or surgery. If that's the case, then we will prescribe something adjunctive. Secondly, if the majority, let's say for the sake of argument, the majority of the tumor is removed at surgery and years go by and that tumor does not grow, and then 10 years later, an imaging study shows that that tumor has started to grow, that would be the time. So the regrowth of the tumor would trigger adjuvant treatment, which hopefully would not need to be surgery. And I say hopefully because if we prescribe the appropriate imaging schedule, and that usually is once a year or once every 2 years, we can catch the growth of the tumor before it gets too big for the radiation technique that we talked about. Remember, 3 centimeters or 1.5 inches is the maximum that we can use the gamma knife. So we want to make sure that we catch the tumor if it's going to grow and prescribe that modality of treatment before the tumor gets too big.
Thank you. A couple of our viewers have asked about calcification, which you touched upon. Can you please explain what it is and what role it plays in the tumor itself?
Sure. Some meningiomas can produce calcium. Calcium, of course, is the hard part of bone. That's what makes bone hard, it's what makes teeth hard, and so forth. And calcium can actually be inside meningiomas. Obviously, then, that changes or that affects the consistency of the tumor. And remember what we said about consistency, the firmer tumors in consistency are much more difficult for the surgeon to remove. Good news is you can tell whether tumors have calcium in them on either CAT scans or MRI scans. And so the surgeon or the doctor managing the patient's tumor can give sound advice as to what the chances are that the surgery is going to be relatively difficult or what the chances are that the surgery is going to be relatively easy based on the amount of calcium that they can see in the scan. I have to say that calcium alone is rarely ever an impediment to getting a complete removal of the tumor. So calcium does affect the consistency of the tumor, but not so much that it keeps the surgeon from getting the tumor out. It's other fibrous tissue that causes high tumor consistency that actually keeps the surgeon in certain circumstances from getting the entire tumor out.
Thank you. Can you please speak a little bit about some of the common side effects that you see in patients as a result of surgery or radiation, and how some of these side effects are managed or addressed?
Sure. Of course, the tumor itself may cause symptoms, and those symptoms are usually due to pressure, but they also can cause symptoms due to swelling or edema. And so after the treatment, the doctor that performed the treatment is going to follow the patient for the hopefully mitigation of that swelling and that edema. We know that after surgery or even after radiosurgery, those two treatments can cause swelling. So that's one of the potential complications. That swelling, depending on where it is located, can cause symptoms. It could cause headache. It could cause memory problems. It could cause imbalance and so forth. And so the post-operative images, such as MRI and CAT scans, can show the doctor why the patient may not be recovering nicely from what was otherwise a successful treatment. And if that swelling has flared up after the surgery, then many times the surgeon will treat that with steroid medication for several weeks, which we know will accelerate the resorption of that edema, which is actually just water in tissue. And a lot of times that'll have a salutary effect on the patient's symptoms. So that's probably one of the more common ways in which a patient will not experience immediate relief from the tumor being removed. Of course, depending on the size of the tumor and whether the brain had to be gently retracted away in order to get at the tumor, will cause sometimes what we say is an exacerbation, which means increasing the symptom that brought the patient to the doctor's office and caused the tumor to be diagnosed to begin with. And sometimes even when the tumor is removed, the effects of the surgery will linger, maybe weeks, maybe even months. And then if the tumor itself has been large enough so that it actually caused permanent damage to the brain before it was removed, then obviously the patient may have lingering symptoms for a protracted period of time and not get back perfectly back to normal. And so that has a lot to do with the risks of the surgery, and it has a lot to do with, as you know now, the location of the tumor and how successful the surgeon was at getting all the tumor out, or how successful the radiosurgeon was at treating the entire tumor with radiation.
Thank you. And we have time for one last question. And the question has to do with symptoms that wouldn't be typically associated with the part of the brain where the tumor is. So for example, one of our viewers reported that he had a loss of smell even though his tumor was in the frontal lobe. And we've had several callers here at the ABTA who have had symptoms that wouldn't be expected based on the tumor location. Do you have any experience with this and any information you can share about that?
Sure. So a tumor in the frontal lobe is definitely close to the olfactory nerves, and so it can affect smell. But remember, you can have two things wrong with you. You can have a meningioma somewhere in the head, nowhere near the smell nerves, and you can have what's called anosmia. And I know people, friends of mine, who have developed anosmia later in life. They've lost their sense of smell. And I always tell them, well, get a scan, make sure you don't have a tumor up there. And they get a scan, there is no tumor. So they lost their sense of smell due to some other reason, not related to the tumor. So that definitely can happen. We get these tumors, as I said, in our middle age and in the latter stages of our life. And a lot of things can happen to us, and a lot of things can happen to our brain at that age. And so it's not that uncommon for somebody to have symptoms of some weakness or paralysis because they had a small, what's called a lacunar stroke. And then when they get a scan, we can see the little stroke, but we can also see a meningioma. And in that circumstance, it's usually relatively easy for the neurosurgeon or neurologist that diagnose the tumor to separate out what is causing what in terms of the symptoms. So it's not uncommon for somebody with a meningioma to have another neurological condition that isn't related to the tumor. So then a frank discussion about the goals and objectives of treatment has to be had so that the patient doesn't have expectations of recovery of something that the tumor isn't responsible for.
Well, that is all the time we have for questions today. Thank you once again, Dr. Giannotta, for your wonderful webinar presentation. And just a couple announcements before we sign off today. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their brain tumor experience. The ABTA National Conference brings together patients, caregivers, researchers, and medical professionals from around the country to network and gather up-to-date brain tumor information through first-class educational programming. Join us in person in Chicago, Illinois, or via our live streaming platform this September 6th and 7th. For more information and to register, visit abta.org/national-conference. The ABTA also hosts regional patient and family meetings across the country. Check out our website, abta.org, to find a meeting near you. The ABTA's Breakthrough for Brain Tumors 5K run and walks currently take place in 10 cities throughout the United States. And as Dr. Giannotta mentioned earlier, we do have an event coming up in Los Angeles later in the year. We are gearing up for our fall events, and we would love to have you join us. Please learn more by visiting bt5k.org. For more information about ABTA's programs, events, and services, visit our website, abta.org, email us at info@abta.org, or call the ABTA care line at 800-886-2282. This concludes our webinar. Thank you for joining us, and please be sure to complete the evaluation survey you will receive by email within the next 2 days. And thank you again, Dr. Giannotta, for a great presentation.
You're very welcome.
You may now disconnect.
Okay. Disconnect the phone, right?